Good afternoon, everyone, and welcome to the Board of Pharmacy's webinar today. I'm Tom Glenski, Chief Inspector with the board, and today we have an update from HealthNet's Program Integrity Unit. Let's see, today's presenter is going to be Olivia Rush, PharmD she's a pharmacist at the Program Integrity Update. And at this time, Josh the director of the pharmacy program, has not been able to join us. He may join us later on during the webinar. Before I turn it over to Olivia, I will go through some basic information about our program today. All the participants are muted in listen-only mode. If you have any trouble with audio via the computer, you can call in using the dial number and access code listed on your GoToWebinar toolbar on your screen there. The program has been approved for 1 hour of a continuing education. You must be logged on to GoToWebinar under your own username to get credit. You don't get credit if you're logged in and watching as a group under someone else's login. At the end of the program, I'll give more instructions on how to get CE. A reminder, we do not submit CE to the CPE monitor, so make sure you save your certificates that we email out to you. Handouts of the slides today are in two places. You can find them on the board's website. On the left side, the upcoming events tab, you can click that, and then you'll see a link to the handouts under webinar number 1 section on that page. Or on your GoToWebinar toolbar, there's a tab called handouts. If you open that, you'll see there's a handout PDF listed, and you can get them there. We do record our webinars, and you can find all our past webinars on our web page under the news publication and resources link. Olivia will take questions at the end of the program. If you'd like to send a question to her during the program, go to your toolbar, type in your question, and hit send. And so now I'm going to turn it over to Olivia. Thanks for coming today, Olivia.
Yeah, thanks for having us, Tom. We're really excited to be here. And like Tom mentioned, my name's Olivia Rush. I'm the Program Integrity Pharmacist over at HealthNet or Missouri Medicaid. And I'm here today just to kind of go over general updates and then things that I'm seeing within program integrity world. So a lot of times when people think of program integrity, they think of fraud, waste, and abuse. So I'm going to provide a little bit of an overview along those lines. Again, go into a little bit more of my roles and responsibilities, and then also hopefully educate you and give you guys the tools to appropriately report fraud, waste, and abuse. Along at the very end, wrap up with just HealthNet program updates. So according to CMS, or Centers for Medicare and Medicaid Services, in fiscal year 2020, there was an estimated $86.49 billion in improper Medicaid payments, throughout the United States. This equaled out to roughly 21.36% in improper payment rates. Now, these contributions are across all aspects of the healthcare sector, but today we're really going to focus in on the pharmacy program. So I've listed a few examples on ways that fraud, waste, and abuse is used or abused in pharmacy. So writing and filling illegitimate prescriptions, forging or altering prescriptions, rendering inappropriate or unnecessary services. And I'll kind of go into a few other details or specific examples that we found here in a little bit. Dispensing excessive medications and billing for the same service multiple times. Again, I've got a few examples to walk through here. HealthNet actually reimburses providers $1.3 to $1.4 billion each year, as we have roughly 1 million prescriptions dispensed every single month. So if we were to apply the logic that I mentioned above, we could potentially have $3 million in improper payments. So it's very important for us to take these steps and to provide education on ways that everyone can play a role in preventing fraud, waste, and abuse. So I pulled up a definition slide here. I'm not going to go through each one of these. You will find these definitions within our HealthNet Pharmacy Manual. But one thing that I want to really focus on is the key difference between fraud, waste, and abuse, and that being intent and knowledge. So if you read through the definitions, you'll see fraud has the word intentional in it quite often. So this requires a person to have an intent to obtain payment and knowledge that their actions are wrong, while waste and abuse may involve obtaining an improper payment. It doesn't require that same intent and knowledge. Again, these definitions are more for your information, and I'll walk through a lot of different examples that we see that, or as I walk through examples, you'll see not everything that I'm looking for is for fraud. We see a lot of misbillings where there just needs to be education, where there isn't that intent or that malice to have overpayment. So many of you may not have heard of Program Integrity Pharmacist with HealthNet. This is actually a brand new role that was created in September of 2020. So I'm a year over in this role. And I have a lot of different daily activities that I do and different job responsibilities. One being working with other sister agencies that include MMAC, or Missouri Medicaid Audit and Compliance, MFUCU, who is the Medicaid Fraud Control Unit, which is within the Office of the Inspector General, and along with the Missouri Board of Pharmacy, where we work together to investigate leads and different concerns that we see within the fraud, waste, and abuse community. Whenever we do identify different issues and things along those lines, that leads us to develop new policies and procedures, or just recommending enhancements to our current edits that we have in place. So again, those are some overarching responsibilities that I have. On my day-to-day, I do a lot of post-payment reviews, and I continually conduct analytics via data mining of validated encounter data to help me find and identify leads for fraud, waste, and abuse. And a lot of times when I'm doing these post-payment reviews, the end result is actually provider education. That's one of my favorite things that I have about the job, is the ability to pick up the phone and have a conversation whenever I do identify a misbill. Again, not necessarily fraudulent, not necessarily with intent, but just to have that ability to provide education. And a lot of you might think too, well, why a pharmacist? So I'm looking at a lot of the outliers, and initially whenever you pick out an outlier, it may be fiscally, it may look inappropriate, but it's important to have the clinical background that a pharmacist does to look at these in a different way, where the increased quantity on a prescription might actually clinically be relevant for the patient to have. So I've already mentioned fraud, waste, and abuse quite a bit, but that's not the only thing that I focus on. I have a lot of other initiatives, and one that I want to highlight today is our out-of-state non-bordering pharmacies fiscal edit, which was implemented back in November of 2020. So this is one of the very first things that I started to work with whenever I joined HealthNet. So overall, this edit restricts our out-of-state non-bordering pharmacies to dispense medications that are unavailable by another in-state pharmacy. What that means is a lot of times these out-of-state pharmacies have agreements with drug manufacturers for limited distribution drugs or exclusive distribution drugs that they, again, have those agreements with the manufacturers to dispense, but we're finding that these out-of-state pharmacies are also filling your everyday maintenance medication. So things for blood pressure, diabetes, RA, the list goes on and on. And with the out-of-state non-bordering pharmacies having this ability to fill almost any medication prior to November of 2020, we saw $29 million in spend in state fiscal year 2020 going out to these non-bordering pharmacies. Now, with this new initiative, we've actually brought back in $13 million worth of pharmacy claims to in-state providers. So again, this is another example that we're not just looking at fraud, waste, and abuse, but we're actually helping Missouri in general by bringing the business or the pharmacy claims back to the pharmacies, making sure that we're keeping our jobs and revenue in the state of Missouri, and just overall keeping Missouri money in Missouri. So next I'm going to jump into and highlight a few different, I have it listed as identified issues, and not necessarily all of these are quote unquote issues, but things that I want to, again, provide education and walk you through. So one actually being the waiving of co-payments. So with the public health emergency, HealthNet waived all co-pays, including the shared dispensing fee for pharmacy services during the PHE. And you can see here I have an example of a provider bulletin or provider hot tip that went out in May of 2020 outlining this exemption. And also there on the very bottom of the screen, 22.7, that's the little bit out of our pharmacy manual that you can reference as well. But with the change, we're actually doing this indefinitely going forward. And we understand, MoHealth understands that it would be extremely time consuming and administratively difficult for pharmacies to process hundreds or thousands of small refunds to affected MoHealthNet participants if you have continued to actually charge copays to participants. So we've decided going forward and working with MMAC that we could potentially impose sanctions if we determine pharmacies are continuing to collect these copayments. So this is an informational to let you guys know to take the appropriate steps in moving forward to make sure you are not charging copayments to MoHealthNet participants. I know everyone is probably tired of hearing about COVID-19, and now we're moving into different things related to fraud, waste, and abuse with the vaccines and just COVID treatments in general. So one thing that I wanted to highlight is the Department of Health and Senior Services standing order or protocol that was put in place during the public health emergency to allow pharmacies to bill for these COVID vaccines without having to have a prescription from a primary care. So whenever the protocol was first initiated, Dr. Randall Williams was the authorizing provider. However, on April 20th of this year, Dr. George Turabelitsi is now the new effective provider, and I'm still seeing claims come across with Dr. Randall Williams attached to those. So I have made multiple phone calls to educate providers here in this instance, and we do expect our pharmacies to go back and rebill for the appropriate provider within the time frames that I have listed here on the screen. One other issue that we've identified is pharmacies billing the inappropriate MoHealthNet DCN or ID number. And most generally what I'm seeing is just, again, a misbill. It's not intentional. Was a patient or a parent or a guardian was administered the vaccine, but the vaccine was actually billed inappropriately under a child's DCN. So one, it looks like a child outside of the appropriate age group is being given a vaccine, but when I call, we learn and come to a conclusion that it really was given to the parent or guardian. Some of you might be asking, well, why do we not have stops in to make sure that this is paid appropriately? We as an agency did not want to put in any kind of stops for COVID-19 vaccines, as the EUAs and the approvals was continually changing per age groups. We wanted to make sure that all patients within the appropriate age groups had the ability to get the vaccine. And then lastly, we're also seeing inappropriate age groups per the standing order and EUAs. So I've got listed out here the different age groups. So Pfizer 16 and older, FDA approval, 12 years and older is under the emergency use authorization. Moderna and Janssen are both 18. And I have a link, the very top reference is actually straight to the Department of Health and Senior Services standing order. So if something does change, you have the ability to go and look at that. But the expectation here is if you are using the standing order, you must use the appropriate age ranges. A good example of this being abused is actually the second reference that I have on the screen is an article from the Department of Justice where a pharmacist actually received federal charges for vaccinating those under the authorized age, and they are now facing a max of 5 years in prison plus $250,000 in fines. So one, not only is this a Medicaid issue, this could be an overarching issue for all patients in general. So again, another educational piece that we want to make sure that everyone is utilizing the standing orders appropriately. The next issue that we have identified is circumventing of edits, or pharmacists or pharmacies finding ways to work around the clinical or PDL edits that we have in place. One example that I'm going to talk about is our high-risk therapies edit, where if a patient is on an opioid and benzodiazepine concurrently, we require a opioid emergency reversal agent to be filled within 2 years. So this is not a requirement where they have to receive a naloxone claim with every single prescription fill of an opioid or a benzo, but just once every 2 years. So what we're seeing is when pharmacies receive this rejection, they run a claim for naloxone only to receive an opioid or the benzo claim, whichever is denying at that point in time. And once the pharmacy receives a paid claim for the opioid or benzo, they actually go back and reverse the naloxone claim. So at HealthNet, we actually have the ability to look at every single submission that comes to us line by line in time order, so we can see that the naloxone is ran first, followed by the opioid, the benzo, and then the reversal of that naloxone, and we have the ability to identify those. So every time you hit enter on your POS system and that submission comes to us, we have the ability to have that information and take a look at this. A lot of times whenever I call and educate pharmacies on this issue, I hear a lot of different, I get a lot of different feedback. One being, my patient doesn't want to pay the copay, or they can't afford the copay. Well, like we just discussed, copays are no longer required. Therefore, that should not be an issue going forward. Another one being the primary care doesn't want to write a prescription for the naloxone. Well, good news for you guys, Department of Health and Senior Services also has a standing order for naloxone. Just make sure whenever you do run this one, going forward, again, you're using Dr. George Durability as the authorizing provider on these prescriptions. And third thing that I'm hearing a lot too is, my patient will never use the naloxone. So as a healthcare provider, I think it's very important to stress the importance of the medication and why it's nice for them to have it on hand, and not necessarily for the patient to use, but if a family member, I'm thinking, you know, grandchildren, family members, things along those lines, accidentally get their hands on the medication, it's good to have that on hand. There actually is an example of recently of a child in St. Louis where they got a hold of their grandparents' medication and overdosed and sadly passed away. So again, this is not necessarily for the patient, but for the safety of the population in general. One other issue that we're seeing is white and brown bagging. So white and brown bagging refer to whenever a participant either receives a prescription from a retail pharmacy and takes that prescription to a clinic or hospital for administration, or B, the retail pharmacy fills a prescription and sends it directly to the hospital or clinic for administration. What we're seeing actually is both the retail and the clinic billing us for that same medication when only one should be billing for administration. A lot of times, again, this is not fraudulent or malice or filled with intent. This is a billing issue where the clinic, you know, charts that the patient received the medication, and then it's the billing department that incorrectly reads the chart and assumes that the hospital or clinic actually dispensed the medication. So I've, again, educated multiple providers in this stance to have the correct policies and procedures and provide education to their staff when it comes to billing for these kinds of medications. One other thing that we're seeing in this instance too is with mainly with white bagging, where the medication intended for a participant is sent from a retail pharmacy to the clinic, but the patient actually never receives the medications, or it's never administered to the participant because an appointment wasn't set up appropriately, or other examples in that kind of form. When we learn of these kinds of issues, it actually becomes the pharmacy's responsibility to cover this medication that never was administered to the participant. So again, we're trying to provide education and to make sure that everybody is taking the appropriate steps to ensure that the appropriate patients are receiving their intended medications. Again, at the bottom, I just have a reference, one, to our high-risk therapies clinical edit for you guys to review if you do have questions, concerns there, and then also another link to the naloxone standing order if you need that as a reference. Two of the last issues that I'm going to run through are on this slide here. The first one being inappropriate use of foot baths. So what we have recently found are providers, so including pharmacists and PharmDs are actually prescribed, or pharmacists and providers, excuse me, are prescribing and dispensing unnecessary medications like antibiotics and antifungals for use in foot baths. So what happens is a participant is instructed to dilute a prescription product by mixing them with water, and then to soak their feet in that solution, whether it be daily, weekly, etc. However, majority of these antibiotics and antifungals do not have a compendia for that kind of use. And so this becomes extremely, extremely wasteful. And a lot of times too, the medications that are used are not even water soluble. So they're not even going to appropriately mix in with the water and be absorbed and things along those lines. So we are making steps to recoup these kinds of, or recover these kinds of costs that are wasteful and unnecessary. And the sad truth about this too is, when we find different issues like this identified, it forces us to put restrictions on medically necessary medications for participants. And so it's going to become even more difficult for patients to receive the appropriate medications. And we'll talk through in a little bit the importance of everyone in the community to help fight fraud, waste, and abuse, especially whenever it comes to participants receiving appropriate care. The last issue that I want to talk about, it's not necessarily even an issue, it's just more of for your information for those that submit compounds to HealthNet. What we've recently found is an actual pharmacy system error that results in the ingredient quantities on compound claims to be elevated compared to what the pharmacy actually submitted. So an example being, kiddo needs to have a compound and the quantity is for 120 mils of the suspending agent. So on the very first claim, everything is paid appropriately, everything is billed appropriately, the quantity comes over for 120 mils. But on subsequent fills, there's almost a multiplier that is applied to the claim, and so the claim then comes over for 240 mils on the second claim, and then 360 on the third claim. So whenever we call and have conversations, again, most generally that's where I start, is to actually pick up the phone, have conversations with providers, and we discover that there was a back-end pharmacy system error that resulted in that compounding claim coming over whenever I questioned why the patient needed an increase every single month for a medication. So again, not necessarily an issue, but it's an FYI for some of you guys to look back through and maybe potentially identify this system error on your side. So I just briefly mentioned how important it is for a person to help really play a role in combating Medicaid fraud. And that's to take the initiative to actually report the issue that you see, whether it be like a simple concern, whether or not you know if it is fraud, waste, or abuse. If you have some kind of concern, we really ask for you guys to reach out to us and have communication with us so we can take the initiative to investigate and send it down the appropriate channels. So I have a few different resources listed here on the screen. The first one being HealthNet medication-related fraud, waste, and abuse issues can go to the HealthNet Provider Administration Unit. So, I'm sorry, the Pharmacy Administration Unit. So I have their email and their hotline listed on the screen. Other overarching Medicaid related issues can be sent straight to MMAC, again, Missouri Medicaid Audit and Compliance. So I have their email and their hotline for your reference as well. Another very important step that you guys can take to help prevent fraud, waste, and abuse is actually to stay up to date, and whether that be with laws, regulations, policy changes, things along those lines. We have steps and resources for you guys to take to help be in the loop. And one of those is to actually sign up for our hot tips and provider bulletins. If you follow the link that is provided on the slide, it takes you directly to the HealthNet main page or home page, and the blue box on the left should pop up to have you sign up for our news right away. And so if you enter your email address and hit the subscribe button, it gives you multiple different topics that you can include if you don't want your whole email box to be full of all provider information. It can be directly toward pharmacy, etc. So you have that ability that way to manipulate how many emails you receive from us. And if that blue box doesn't pop up, or if you're navigating through other parts of the HealthNet website, there is the box on the right that you'll see. It will populate in the bottom right-hand corner of almost every single page on the HealthNet website. Again, it's important for you guys to sign up for those just so you guys can stay up to date and follow along with all of our policy changes. So I am going to jump into our program updates. So coming up in October, we're actually seeing quite a few changes, and these are just a few that I'm highlighting. We have more changes than this, but just some bigger ones that I think that are going to impact the provider community. So the first one being the anti-migraine 5-HT1 inhibitors, or the triptan edit. We're actually no longer going to require a diagnosis of migraine or cluster headaches prior to approval. With the GLP-1 receptor antagonist, we are removing the minimum age requirement for the class with the expectation that it's still prescribed appropriately for the intended age range. For neuropathic pain, this one is mainly referring to lidocaine patches and their diagnosis requirement. We're actually going to open up lidocaine patches for multiple pain indications. The SGLT2 inhibitors, we are going to remove the step 3 of metformin and a diagnosis check there. And lastly, in October, changes to the leukotrienes, or to specifically montelukast, where there was a black box warning, still is a black box warning for serious neuropsychiatric events. And we did have steps in place if a patient did have history of having one of these events on their profile, that we did require the provider to take another look at the necessity for the medication. We are going to remove some of those steps because we believe we have sufficiently provided education and awareness to that black box warning. And then coming up in January, you see the anticoags, the antiplatelets, and the proton pump inhibitors. These all three have the same change, where we're actually no longer going to require a diagnosis check for approval on these medications. And I talked about program updates, and I talked about staying up to date. And one of the easiest ways to actually stay up to date and find out about the program updates is through our website. So I have a screenshot up here. You can follow HealthNet Division to Clinical Services Advisory. And then from there, we have multiple advisory committees, one being the Drug Prior Authorization Committee. We have another, the Drug Utilization Review Board, and then our Rare Disease Advisory Committee as well. Those references, or those links to those specific meeting information, is at the bottom. But what you'll find on these respective websites are the topics and the proposed changes that we have upcoming for policy changes. These committees do meet quarterly, so we actually just had the drug PA meeting in September, DUR is coming up in October, and then rare disease will actually meet in November. This also gives you the opportunity for public input if you have questions, concerns in that form. So you can go here and see exactly what we have updates on, or what we have upcoming, or like I said, what we have proposed. I think I actually only have one more slide left, and I'm not sure, Josh Moore, who we did discuss earlier, just stepped into the room, and I'm not sure if he wants to give these updates, or I can go ahead and continue. That's it.
Yeah, so this is Josh Moore, Director of Pharmacy at HealthNet. I apologize for being late and not being here earlier for the presentation, but I am excited that I did get to make it here for Project Hep Cure. We are incredibly invested in eliminating hepatitis C in the MoHealthNet population and really Missouri overall. But MoHealthNet obviously has the capability to really interact quite a bit with MoHealthNet providers and our participants. The only way we're going to get to our goal of eliminating hepatitis C is to screen, test, and treat every one of our MoHealthNet participants. So screening those people that are at high risk for hepatitis C, and that includes actually the general population as a whole. Everybody over the age of 18 should get tested at least once. And then, for instance, pregnant women, they're going to need to get tested each time they are pregnant to screen for antibodies. And then if they do come back positive for the antibodies, then go ahead and test for active infection and then treat. The great part about Project Hep Cure and what has delayed quite a bit of treatment, we think, in the continuum of care is really the prior authorization requirements needed to treat our MoHealthNet participants with these fantastic cures that are available now. So in effort to support our elimination strategy in Project Hep Cure, we've actually lifted the prior authorization requirements on the Maverick product. And we also allow Maverick to be dispensed to our MoHealthNet participants for up to 16 weeks. For about 98% of patients, you're going to see just an 8-week treatment results in a cure. But there are certain patients that do require 12, 16, and very few instances 24 weeks of therapy. So we really made that an effort, and we're trying to educate as many people as we can. The great benefits we're going to see is reduction in HCV burden just across the state. Ultimately, that's going to result in a reduction of the related liver disease that you often see. And then, as we talk about testing those pregnant women, we can't treat pregnant women just yet. The evidence isn't quite there for most of them, but what we can do is identify the mother and treat her after she's delivered the baby. And then we can also identify the infant so that when they turn 3 years of age, we can go ahead and test them as well and get them treated as early as 3. So really working very, very hard to eliminate hepatitis C. I talked about already the prior authorization requirements. My help desk is very excited that they do not review these anymore. So these are very easy to process for us. Whenever you get a prescription in your pharmacy for one of these products, they will just process through just like a standard antibiotic would. So no requirements on the provider, no requirements on the pharmacy for Maverick specifically. We also have a bunch of information on our website, and you've probably all seen a bunch of the information going out about the education. And the education piece for hepatitis C is incredibly important. We think there's about 6,000 patients that we've identified on MoHealthNet who actually have an active infection for HCV. We haven't treated nearly that many yet. We know that if we line up all those patients at our specialists across the state, in the 3 years that we're really coordinating this project, we will not get through all of our patients just relying on specialists. So we really need to see a lean in from our primary care providers, our nurse practitioners, really anybody that sees our patients should be helping out in eliminating hepatitis C. One of the things we often get questioned on is my patient is still an active IV drug user. They're still an active drug user of one kind or another. I'm not going to waste money or time to treat my patient. We've heard that across the state. There's two things that I say to that. We don't wait for our diabetics to stop eating donuts and carbs before we allow them to go ahead and get insulin. The other one being our hepatitis C infected patients. When they get infected and they go and do IV drug abuse with another group, on average, they will infect within 3 years 20 other people. So if we think we're saving money by not treating somebody, really what we're doing is postponing, and we're about to spend a whole lot more money as we try to then treat 20 plus people. The other thing to think about, of course, is in that needle, that syringe, HCV can actually live for 9 weeks in a syringe after somebody infected with hepatitis C has utilized it. So it's very important that we're counseling these patients on safe practices, but also treating them as well. If you have more questions on Project HepCure, like I said, the website below, you've got a number of emails most likely from HealthNet regarding educational opportunities. Our weekly training for the month of October starts this Friday. You do get CE for it. It is at noon, and you do have to watch live, but we're very excited about doing that training.
Okay, so we're ready to go take some questions. Give us a minute so Olivia and Josh can review some of the questions that came in, and we'll be back in just a minute to start maybe answering some of those. If you would like to send a question, go to your toolbar, type it in and hit send, and we will get it here. So we'll be back in just a minute. Okay, so we're back, and I'm going to turn it over, and if you guys just want to read it.
Yeah, and I'll go ahead and answer. We got a couple of questions regarding our co-pays for HealthNet participants on prescriptions. So one of the questions is, we took away co-pays, but we didn't increase reimbursement by the same amount. And I can tell you that HealthNet Pharmacy was the only Medicaid program that I am aware of that actually allowed the copay to be in addition to the full reimbursement for the product and the dispensing fee. And actually, in a review of federal regulations, we are not allowed to have the copay be in addition to the full reimbursement for the product. So if copays were to come back for HealthNet pharmacy participants, the amount of the copay would be deducted from the reimbursement amount you are seeing today. So when you look at a product, if we were to reimburse the pharmacy for the full reimbursement of $10, and this is a fictitious example, but if it was $10 and the copay on that product was $1, then in a world with copays, as it would come back, would mean that HealthNet would reimburse you for $9, and then you would be expected to get the $1 from the participant. And again, remember that for Medicaid, the ability to pay the copay cannot restrict them from receiving the product. The other question we have is, are copays waived for dual eligible patients with Medicare plus MoRx for long-term care patients? So MoRx is actually not strictly a Medicaid program. What we're doing with MoRx is we are paying half of the Medicare copay. So for instance, if a copay was $3, we pay $1.50, and then you would be expected to pick up the other $1.50 from the patient. All right, the next questions are really regarding white bagging. We would expect the pharmacy and the provider who is administering the medication to coordinate to ensure that there is an appointment, that they have contacted the patient and set up all of the necessary appointments and transportation or anything else they might need to really ensure that you're doing everything you can to not waste taxpayer funds and waste valuable medical resources. Some of the items that we've seen have been where the pharmacy gets an order and goes ahead and just automatically ships the product out, and the appointment hasn't been set up. There's been no coordination whatsoever, and then we end up wasting $6,000 a dose. That's incredibly frustrating for, I think, everybody on the call as we look at ways to ensure that our resources are used appropriately. $6,000 expiring on a shelf somewhere does not a single bit of good for anyone. That $6,000 we could have poured into taking care of patients, reimbursing pharmacies more, reimbursing other providers more. But instead, we got to pay for a wasted dose of a medication. As far as the next question, what's the pharmacist's responsibility for the new PDMP physicianing monitoring program? That was actually a requirement that came out of the Support Act, which was signed by President Trump in 2018, which required prescribers to check the PDMP prior to prescribing a controlled substance to a Medicaid participant. Pharmacists cannot prescribe controlled substances that I'm aware of in the state of Missouri. I haven't seen that come across quite yet. So ultimately, that means that there is no requirement for the pharmacist to check the PDMP prior to prescribing a controlled substance under the Support Act requirements. That lies solely on the prescriber and the prescriber's office. The prescriber can delegate that requirement to one of their staff, but they definitely need to document it in their chart. There's a very specific question about what looks to be expired NDCs or expired product where the manufacturer has reported to Medicaid that there is no more product on the market which has a good end date on it. And in those cases, we rely on the manufacturer to tell us the truth about what the last lot of good non-expired drug is. And then if a pharmacy dispenses those products past what the manufacturer is telling us is a good date, then we do go ahead and recoup those claims if any made it through. We, in our system, if we're alerted ahead of time by the manufacturer of that fact, then we will go ahead and stop paying for the particular NDC so that you don't get into a point where the claim goes through for a product and we ultimately end up having to recoup it later on. Yeah, so got a question here about what we're looking for with vaccinations and using the correct doctor on the standing order. That really ties back to making sure that as you administer vaccines, that you are really looking at what the standing order is for and then administering accordingly. So we had the instance, of course, I think Olivia went over earlier, where Dr. Williams left the agency. And so those all transitioned over to Dr. Terbelisky. So Dr. T, it was the person on the standing order going forward. So we needed to make sure that providers, of course, should have been utilizing the correct standing order. With COVID vaccine, anybody that is administering COVID vaccines and getting those from the state or the federal government should be getting notices anytime there's an update to the standing order, or the age groups or the other various items that have been changing. We know that these are changing rapidly, and it's important for providers that are administering these items to follow very, very closely with the standing order to make sure they're not administering it to a group that is not supposed to receive it. Olivia has worked very hard to work with the pharmacy providers to notify them of anybody that looks unusual, that doesn't meet the standing order. And that really helps us work with the pharmacy to stop billing that's incorrect, so that you don't get quite the backlog of items that may be billed incorrectly. But it also makes sure that federal government property isn't used inappropriately. I think she probably went over the pharmacy that ended up getting prosecuted by the federal government because they were using the COVID vaccine incorrectly. Another one was highlighting the rule of benzodiazepine and opioid naloxone dispensation. So for that, what we're looking for is if the participant is on a benzo and an opioid, they need to have naloxone on hand at least once every 2 years. That's because they generally last for 2 years. So that's what we want to make sure they have, one that actually works whenever they may need it, or somebody else in their household may need it if they accidentally ingest some of the medications available. This is an incredibly important risk reduction policy, and we are very excited to see our number of naloxone prescriptions go up a tremendous amount. We do not require naloxone with every single fill of benzos and opioids that a patient might receive. It's truly just once every 2 years. So for those pharmacies out there that are doing it every month, you don't need to do that. You can just do it once every 2 years for that patient. Question on if the primary insurance requires a PA, can we use the override that drug isn't covered without attempting to get a PA? No. That is something that we are working incredibly hard on to make sure that people's primary insurance is paying for the products that they should be paying for. The state of Missouri Medicaid taxpayer dollars should not be going towards the full amount of paying for a prescription when there is a third party out there that should be paying a sizable chunk of that drug cost. We see a number of those where it comes across, say for instance, Humira, and we used to see it where they would come and it would say PA required from the primary, and then HealthNet would pay the full amount. Now, there are extenuating circumstances where the primary insurance may ultimately deny the product, and those we handle on more of a one-off basis. HealthNet reimbursing pharmacists for sub-Q regen, the monoclonal antibodies. We are reimbursing pharmacists for that. You utilize the same CPT codes as the other providers. We're working on a bulletin so that providers know how to bill those. Every draft we make, the federal government makes another change. So we've been in draft mode for a while. When we do put out the bulletin, we're going to basically say this is the requirements as of today, because I think as everybody's been dealing with the federal government, those have been quite frequent changes that have occurred. So just want to make sure we're going to put that notification out so that we're compliant with the PrEP Act as well. Got a question on the CE program for hepatitis C and Project Hep Cure. Show Me Echo is going to be the website you should go to. Show Me Echo is the group that we're partnering with. We've also, if you've signed up for our emails or gone to our website, you can see it there as well. But Show Me Echo is going to have the sign up for the webinar series. There's one a week for the next 4 weeks on Fridays at noon. They will be recorded, but you have to attend live in order to get the CE credits. And the topics for each of the weekly trainings are available on the website for you to peruse and decide which one you want to do. Another question on how do we get reimbursed for administration of a long-acting psych med such as Risperdal Consta and Invega Trinza? You have to enroll as a HealthNet provider as a pharmacist, and then you need to bill us a CPT code. And I don't know that CPT code off the top of my head, but it is available on our website when we posted a bulletin to let you know exactly how to bill it and then the reimbursement for it. If you'd like a list of our medications that can be dispensed for 90 days, that's also available on our website under frequently updated documents. So there's a list on there that are the ones that are going to be required to be 90 days after somebody's established. And then also the list that says these are the medications that you can do up to 90 days or longer due to package size and those types of things. I'd like to take this moment again to remind people on birth control specifically. For birth control, we will pay up to 1 year at a time for a birth control. So if a patient walks in and they have a 12-month prescription, we will gladly pay for them to receive 12 months of their birth control. Last question I'm seeing there, HealthNet reimbursing pharmacies for Hep C testing. We are working on a larger regulation in terms of pharmacist provider services, and the reimbursement for pharmacists for all of those services will be in the new regulation to ensure that we can reimburse pharmacists for those things that are within their scope of practice. We're not quite ready to share a list of those codes or items, but we are trying to keep a broad idea on the regulations so that as more opportunities come up for pharmacists through the board and through the General Assembly, that we can adapt to those quickly and allow for payment.
Okay, so this is the last call for questions. If you have any, please submit them. Is there anything else you guys want to talk about while you're here today?
I think we've covered a lot of the highlights and things along those lines.
And I did get a text message. The code for the administration of those long-acting antipsychotics is 96372 with a TT modifier. All right, last question it looks like is coming in, and it's one of my favorites. Why can't we get a list of OTC covered NDCs? Because they change weekly. Quite literally, they change weekly. And the way this works through Medicaid programs is a complex system where they have to agree to participating in the Medicaid program at a federal level. And even though one OTC item might be part of the Medicaid program, another one might, they can voluntarily leave and join the program randomly. And to manage that and provide a list every single week would burden us to a point that would border on ridiculous. Also, we know a number of providers would print that off and assume it is the Bible, and it is not. It can change every single week.
Okay, so let's, we'll close out here. Our next webinar is going to be on Thursday, October 21st. It's a different topic than our usual ones. This one is a well-being, mental health, suicide awareness, put on by Bart Andrews, PhD, and Shelby Lang, PharmD. They'll be here to talk about us on what you can do to help you or someone else you know in need of this help. As I mentioned earlier, we do recordings of all our webinars. If you go to our website, it usually takes approximately 2 weeks before we get them posted, but you can find all our previous ones that we've had this year. Here's a list of what we've had so far this year on our website, plus previous years are on there too. For continuing education, you must complete the post survey to earn CE credit. So at the end, do not close your browser. I will say I'm going to close the webinar. After I close it, you will get a little window that tells you I have closed it. You would hit close on that window, and again, do not close your browser, and a survey will then open up. You answer the questions and click submit. Should you not get the questions, You can email us at compliance@pr.mo.gov, and we will email you the questions. However, to get CE, you must have the answers back, email the answers back to us within 24 hours for credit. Again, we will email out certificates in approximately within the next 30 days. So I want to thank Olivia and Josh for coming today. Very informative talk. We look forward to having you back in the future again for updates. And I want to thank everyone for joining our webinar today. I am now going to close the webinar.